Namaskar, dear viewers. Welcome to today's Critical Lines. And today we have Dr. Chandrashish Chakravarty as our expert. So, to introduce him to you, he is MD Anesthesia from AIMS. And after that, he has done MRCP in medicine from UK, FRCP Edinburgh, EDIC, and the specialty exam for MRCP in respiratory medicine and the European Diploma in Respiratory Medicine. So, really, that's a very impressive bunch of academic qualifications and all passed with taking the exams, not just honorary fellowships. That's a lot of hard work and excellence. So that's great. Then he's senior consultant Manipal Hospital and head of critical care at MMK Hospital, Kolkatta, India. He won the Young Lecturer Award at ESICM Lives 2017, and he was speaker at ESICM Lives 2023. And he's a teacher and examiner for critical care and anesthesia for DNB, and is also an examiner for MRCP. And he was a gold medalist during his MBBS days. So that's really remarkable and a load of achievements, Dr. Chandrashekhar sir. Very well done. So now we shall start with our questions. So, Dr. Chandrashekhar sir, we have fentanyl, we have propofol, we have dexmedetomidine. So how do we choose amongst these when we have to decide about sedation in a patient?
Right. So, first of all, I would like to thank Dr. Bansal for, first of all, inviting me to this session, and secondly, for such a kind introduction. This is a very relevant question today because very recently in this month, May 25, we got a large study published in JAMA, the Dexmed or clonidine-based sedation compared with propofol in critically ill patients. This is called the A2B randomized clinical trial. And that has unfortunately didn't find any difference between propofol or dexmed-based sedation as far as the duration of ventilation is concerned. But we clinically we try to follow certain basic, principles while sedating our patients. So for patients where we want a light kind of an analgesic sedation, in those patients, opioid-based sedation with fentanyl is good enough, where we want to keep them rather awake but pain-free. So nowadays, remifentanil has also come, and that can be used as well. Dexmedetomidine, the advantage is that it has got, it maintains your sleep pattern. It does not cause that much of delirium. And it is not only useful for patients on ventilator, but sometimes we find that patients on non-invasive ventilation also get very restless, confused. So if you can monitor them correctly, you can use dexmedetomidine for even sedating patients on non-invasive ventilator. In some countries, they use, although in India it is not very popular, but in some countries they also use clonidine for sedation, just like dexmedetomidine. The problem with clonidine is that it causes more bradycardia, more hypotension. So you need to be careful while giving dexmed because it can cause bradycardia, especially if there should be standing orders that if the heart rate is coming down significantly beyond a particular limit, they should either decrease the dose or stop the dose, and there should be somebody monitoring it. Also, there has been reports of some problems with pacemaker functioning in those giving who are getting dexmedetomidine. So if you're on a pacemaker, it's better to avoid dexmed. Propofol, on the other hand, primarily causes hypotension. It is okay to use vasopressors like norepinephrine, as used in many countries, to support that hypotension, correct the hypotension. Particularly, propofol is useful for neurological patients and liver patients, where it does not cause much of a interaction, and you can quickly stop it to assess the neurological changes. And it also advantages that it decreases the intracranial pressure, which is an added advantage of propofol, particularly for neuro patients. So this is the basis in which we kind of decide how to sedate our various patients. And as far as studies are concerned, there has been multiple studies, the largest being the MENS trial, where dexmed and propofol were looked at. And they basically found the significant difference between propofol and dexmed, as dexmed being superior as far as the ventilator-free days are concerned. Thank you.
Thank you, Dr. Chandrashish sir. So I think one of the key messages here, Dexam causes less delirium. That is very important. Now, moving on to the next question, what is refractory shock? Rather, I should put it refractory septic shock because that is where it really matters. And what is the best approach to treat it?
Right. So refractory septic shock is something then when we say that, we mean that we have already done the fluid resuscitation and the patient is on a significantly high dose of norepinephrine, which is now the first line treatment for septic shock as far as vasopressors are concerned. Now, then what are the things that we add to it? Most of the time, once the norepinephrine doses are high, we use vasopressin as a second vasopressor. And although it's not very clear at what dose, but usually once the dose is crossing 0.25 or 0.3 mics per kg per minute, this is probably the point where vasopressin is used. There are various studies which have shown that early use of vasopressin should also be followed by concomitant use of hydrocortisone, especially whenever you're using vasopressin, we should probably add hydrocortisone at the same time to give the maximum benefit, and also to prevent further renal injury or septic AKI. Now, beyond this point, when the patient still remains hypotensive, then what to do? The next few things are rather, there's not very good data on it. Methylene blue is one thing that can be used in septic shock as intravenous infusion or as bolus. It basically works by mopping the nitric oxide. There are studies with angiotensin 2, but then this is Athos 3 trial, but then it is not commercially available till now for us to use. So many a times we add adrenaline to it, although there is not much of a scientific justification. Instead, we can simply go up on the norepinephrine. As far as the pure vasopressors are concerned, like phenylephrine, etc., it can be added at times where the patient is having very high heart rates, which are going up because of catecholamines, like adrenaline, etc. So pure vasopressors like phenylephrine may be tried, but these are all very desperate attempts. Beyond that, ECMO may have a role, but in septic shock particularly, the role of ECMO is still not very clearly defined.
Yeah, thank you, Dr. Devashish sir. Chandrashish sir. Also, I think one would also have to look at the heart once at this point in time and see the LV function. And if it's going down, then
Yes,
probably
absolutely.
iron proof. Okay.
Yes, all that is absolutely, whether there's a concomitant cardiogenic shock going on, whether source control needs to be done, all that needs to be looked at.
All right. Thank you for the answer. We move on. In whom and when and how should VV ECMO be initiated to maximize the benefit while minimizing complications and costs?
Right. So VV ECMO, the primary indication is basically patient with respiratory failure. So so there is good data that in severe ARDS, if from both the Caesar trial and the Eolia trial, that if we can choose our patients well, and if once we have tried proning and it has failed, then it makes there is significant advantage in doing VV ECMO. So can we predict the mortality of what will be the predicted mortality or success if we put somebody on VV ECMO? So there are some scoring systems like the RESP scores, the preset score, and these scoring systems are available on the internet. And you can, based on the age, the duration of ventilation, immunosuppression, renal failure, shock, etc., you can predict to what extent this patient will benefit from a VV-ECMO or not. The general rules, there are many scoring systems to put somebody on ECMO. The most widely used is the Murray score. But for to just as a take-home message, I'll say that if the PF ratio, the PaO to FiO2 ratio is falling below 80, even after everything has been done, that means PEEP has been optimized, the patient has been pruned, etc. Or some people will say below 60, beyond a duration of, say, 3 to 6 hours, then we should be talking about putting somebody on VV-ECMO. The more important indication nowadays has become hypercapnia. So the PCO2 is going above 60 and a pH is falling below 7.2, and we are not being able to improve this, being restrained by the limitations of what we called lung protective ventilation, then we should also think of doing VVEC.
All right. So thank you for the answer. Next question is, what is breath stacking and its implication, and how do you manage it?
So breath stacking is basically a kind of air trapping that happens when the when the expiration is not complete. That means the person is not being able to exhale completely, and this is particularly a problem for patients with reactive, bronchospasm, either because of asthma or because of COPD, or even sometimes on a ventilator because they are double triggering, or sometimes even patients who are very young, very muscular, and kind of breathing so rapidly that they are breath stacking. All that can happen. What happens is basically the tidal volume with each breath keeps on going up. So that causes volute trauma as well as decreases venous return, and it can cause hemodynamic compromise. So while setting ventilators, etc., on these patients, we should be careful. Even when the patients are not on ventilator, we should have a very close watch on them, that are the hemodynamics getting compromised, etc. Particularly if these patients are breathing very rapidly. So what are the ways to decrease it? The best way is to prolong the expiration. So either you can increase the flow in some ventilators, or you can decrease the IE ratio so that the expiration is prolonged. You can try to relieve the bronchospasm by giving bronchodilators or sometimes steroids. You can try to clear the airway by a good suctioning or bronchoscopy. And if there is any other constriction in the airway, like, if you can increase the size of the endotracheal tube, like for example, there's a 7 tube, if you can put an 8. So all these will help in decreasing breath stacking. But most important is prolonging the expiration, decreasing the respiratory rate, increasing the flow, and relieving the bronchospasm with nebulizations.
All right, thank you for the answer. Next question is about cardiac intensive care. These patients who come in with acute cardiac dysfunction, acute cardiac symptoms, and are thought to have acute myocarditis. And the diagnosis is clinical, and you really don't get an etiology most of the times. You think it's viral or maybe some other acute myocarditis etiology. So, what is the empirical treatment for these patients, especially any specific treatments in terms of steroids and IVIG and all this?
Yes. So acute myocarditis, most commonly they are viral that we see, and we really don't have much to offer except for supportive care. Uh, if they're hemodynamically unstable, we try to give some inotropes. If they are developing heart failure, we can give positive pressure ventilation, or we can, give diuretics. Uh, if Sometimes we try to control heart rate by drugs like ivermectin, because in these conditions, beta blockers are usually not uh, very. It's a difficult decision to give beta blockers most of the time. Now, as far as steroids and IVIG are concerned, it's a very debatable area. So there is not a very clear indication when we should probably give steroids in these patients. Uh, um, there are some toxins which can cause severe myocarditis, cardiomyopathy. So again, in these patients, we need to buy time. If clinically, if with medicine we cannot do much, that means if the patient is going down, then these are good candidates for a VA ECMO. Most of the myocarditis, especially viral myocarditis, do recover. So VA ECMO is something that should be considered early in these patients before they go into very bad kind of refractory shock. And arrhythmia managements, electrolyte managements, all these also become very important as supportive care for these patients.
Yeah, thanks. So actually, we probably will be needing a cardiologist help here, and there's this differential of something known as giant cell myocarditis also in acute myocarditis. And for these, it's said that probably steroids and IVIG may help. So because you do not know the etiology, short of a biopsy or really kind of a MRI, we need the help of a cardiologist, but probably IVIG and steroids may help in these patients because there are other etiologies also. And like I said, one of the considerations is giant cell. But this is, like you said, a debatable area. But I would probably give IVIG and steroids also. But it's a
Yeah,
debatable.
IVIG, maybe we can give it a thought. The only thing about steroids is that because influenza and influenza-like organisms also causes myocarditis, we should be very careful to rule it out, because as we know that steroids in influenza has got its own problems with secondary aspergillosis and other secondary infections. So that is the only thing we should be kept in mind. And biopsy-based diagnosis, at least in my centers, we have never been able to do it with the help of our cardiologists. But if we can, if the centers are skilled enough, then that's a good thought that if it's a giant cell myocarditis, we should think of immunosuppression.
Okay, moving on, you talked about influenza, Dr. Chandrashish. So can you tell us now what is the current treatment strategy for severe influenza?
So, severe influenza, basically, we should, if we want to treat them with antivirals, then we should treat them early. And the most common drug that we all know is oral or oseltamivir. So oseltamivir, especially if the patient is having respiratory distress, pneumonia, oxygen requirements, these are patients where oseltamivir should be started, best started within the first 5 days. But the problem sometimes happen is that if you cannot give them oral. Now in our country, nothing much is available beyond that. But in some countries, we can get intravenous preparations, which is called peramivir. Peramivir is intravenous. If it is available, then these are options. And other than that, there are some experimental drugs like monoclonal antibodies, which may be tried. And after that, again, in refractory cases, ECMO or VVECMO is the thing that comes to help. Influenza or influenza-like organisms, viruses which cause ARDS, they have got a much better outcome from ECMO than COVID-19. That's what we have seen. The outcomes are better. So if we know for sure that this is influenza causing ARDS, and if the patient is going down rapidly, we should consider for VV-ECMO pretty early. Other immunomodulators are like steroids are not recommended because we have a fear of something called influenza associated pulmonary aspergillosis or IAPA. So that is something which causes which we should be very careful. And I always try to say that if somebody is coming to you with fever, cough and cold, don't give them blanket steroid before unless it is very necessary, because I have in my practice I have seen quite a few hospital acquired or ICU acquired aspergillosis in patients who came with influenza and secondarily developed aspergillosis in the ICU. So that's my answer.
Yeah. Thank you, Dr. Chandrashish. Sir, last question. How do we balance early broad spectrum antibiotic use with stewardship to avoid resistance, especially in today's world?
Yeah, that's a very relevant question. Um, so the way I keep it is simple, that if the patient comes to me in shock and I'm not really sure that what is the source of infection, then I give them a broad spectrum antibiotic, and I also try to rule out tropical infections. Now, once I get a culture, obviously that needs to be de-escalated. There are situations where unless the patient is in shock or the patient is in severe organ failure, we don't really need to start very broad spectrum antibiotics. Many of us have um, misinterpreted the studies which has shown that there is increased mortality by every hour, etc. But all those studies, whether has been done on septic shock patients, not in patients who have come with fever. So in patients who come with fever, we always have time to do a very uh, a logical decision about which antibiotic is to cover for which organ, and then de-escalate early. One good thing I found when I used to work in NHS in UK is that in their medicine chart after antibiotics, in the antibiotic column, after 48 hours, there was a blank, which means after 48 hours, the nurse has to ask you, the consultant, that should I continue antibiotic or not? Because most of the time, there is really no need of continuing the antibiotics. So Because of this, the nurse is kind of forced to ask that whether it will be continued or not. Otherwise, the antibiotic will stop at 48 hours if there is no yes said during the rounds. So that is, I think, a very nice way of regulating this broad spectrum versus this thing. And we should also try to reduce the duration to 5 to 7 days in most situations, so that we can reduce the total antibiotic load.
Yeah, thank you. So I would just like to add to that. First of all, always de-escalate if you have a culture positivity. There's a big, feel of comfort for the physician to continue the antibiotics even if you get a culture positive. Please stop what is not required. Also, look at your ICU antibiogram. That is very
Yes,
important when deciding what you're going to give. Every ICU has its own antibiogram. I mean, Delhi hospitals will have their own, peripheral hospitals will have their own, and even in Delhi, tier 2 hospitals will have their own. So look at the antibiograms and then they base your antibiotics on the antibiogram. And you should have an idea of what flora and fauna is there in your ICU and what is coming from the community. That is all available with the microbiologist. That is the most important step in deciding about antibiotics. Please de-escalate, and less the better it is. All studies are showing longer durations are not required. Even there was a recent study, I think, which showed for staff 14 days is not required probably, or those kind of things. So we need to kind of decrease the duration also. So I think with that I shall.
absolutely.
Yeah, Dr. Chandrashish, please, what do you want to say? Anything else, sir?
Yeah. No, absolutely. I completely agree with you regarding what you said regarding the antibiotics. Yes.
Yeah. Thank you, Dr. Chandrashish, sir, and thank
Thank
you.
you very much. It was nice talking to you.
Thank you, dear audience, for your patient hearing as always and joining in such large numbers. We shall try to continue and improve upon our programs, and soon we shall be forming a society to give you more educational tools to enhance your growth and to really engage with us and to provide more learning. Thank you very much to everybody. Good night.
Thank you. Good night. Good night, everybody. Bye.